Bismillah ar-Rahman ar-Rahim. Thank you for the presentation, and thank you for the invitation to give this talk. I will be happy to share some of my experience and the way we manage patients in our practice. And I will go all over obesity and how we manage this disorder and this disease, and what different things we consider when we talk about treating obesity. So first of all, obesity has been categorized as a disease in 2014 by the World Health Organization. And that's because of the effect of the disease on the health of people generally, and actually reduction of life expectancy. And there has been obesity has been treated by dietitians for a long time, and actually we had a very serious issue in the treatment where actually maintenance of weight loss has been difficult without any extra intervention. Any issue? So first of all, to diagnose obesity is defined as an excess fat accumulation that causes burden on the human health, and it has been classified actually into different classifications. Previously, it has been categorized as obesity, and then morbid obesity, and then super obesity according to the BMI, which is calculated as the weight divided by the height in meters squared. So obesity has been also defined as a disease by so many different organizations, which actually enhances the definition which we should consider when we treat this disease. So complications of obesity actually appear in different organ systems. So as you know, obesity is related to metabolic complications, not only diabetes, hypertension, and dyslipidemia, but also so many other metabolic factors. It is also related to mechanical complications like sleep apnea, back pain, and even osteoarthritis. And also, we don't forget the effect of obesity on the psychological health, where people are at risk of depression and anxiety. These are retrospective studies which showed the relationship of obesity and increase in weight to different complications, like as you can see in the graph, where obesity is where coronary heart disease actually risk increases as the weight increase, and as the other complications like hypertension, type 2 diabetes, gallbladder disease, osteoarthritis, sleep apnea, and non-alcoholic fatty liver disease. One of our most important complications that we consider when talking about obesity is type 2 diabetes. And as you can see here, the relative risk of developing type 2 diabetes increases alongside with the BMI. With regard to sleep apnea, it has been shown sleep apnea progresses even with minimum increase in BMI. So even 5% increase in body weight might actually double the burden of sleep apnea on patients. Talking about the non-alcoholic fatty liver disease, you can see here in relation to BMI and in relation of waist circumference, the risk of non-alcoholic fatty liver disease increases as the BMI increases. And those who develop fatty liver disease or only steatosis are actually an increased risk of mortality, and also about 10 to 30% of those who have only steatosis will progress into NASH, and then about between 8 and 26% of those patients will actually progress to complete cirrhosis. So how serious is fatty liver disease? Fatty liver disease can actually increase mortality by 8.6% through cardiovascular disease, and by 1.7% through extrahepatic malignancies. And if it progresses to NASH, these figures are actually doubled. Obesity is also associated with multiple cancers. Most notable of them is the adenocarcinoma of the esophagus and pancreas, and postmenopausal breast cancer. Also, we don't forget the effect of obesity on the physical function of the patients, and we can see here the higher the BMI, the least the patient will be active and the least patient will be functioning. With regards to mortality, so normal patients or people with normal BMI are they have about 80% chance of reaching the age of 70 years, and this figure actually goes down to almost 50% for those who have BMI of over 40. If you heard of the term metabolically normal obesity, where the obese patient does not have diabetes or hypertension or dyslipidemia, and one might think that such a patient will not be at cardiovascular risk. Actually, this has been proven to be wrong, that actually this term is not actually completely right, as even patients, as you can see from this slide, even patients with obesity, those who don't have any metabolic complications like diabetes or hypertension or dyslipidemia, they still have higher chances of developing coronary artery disease or cerebrovascular disease and heart failure. So now let's talk a bit about treatment of obesity. So if we talk about lifestyle modification or simply reduction of the caloric intake, what will happen actually, our physiology will fight against the weight reduction. So once someone loses weight, their energy expenditure will go down, and their hunger hormone will rise, and their satiety hormone, including glucagon-like peptide 1, PYY, and cholecystokinin, will actually decrease, and that will lead to increased hunger for the patient and energy conservation, and that will force actually the patient to overeat and regain all the weight they lost. So what I would conclude from this is that actually just lifestyle modification without any extra intervention would make it literally impossible for at least most of patients to maintain their weight loss. So here I would like to show some data with regard to weight maintenance after several interventions. So after a very low energy diet and behavioral changes, or very low energy diet without behavioral changes, you can see there is a very fast weight loss, but sooner or later most of the patient will go back into overeating and then will retain all the weight they lost back. This slide shows when you add a medication actually to lifestyle modification, where you can see more weight loss actually, and the weight loss can be even maintained. Here, this is a study that showed the effects of orlistat, which is a pancreatic lipase inhibitor, on the weight loss and the maintenance of weight loss. So they had 4 groups of patients, and one of them was given only placebo, the other was given an orlistat and then placebo, and then another group was given orlistat and then reduced dose of orlistat, and then the last group was given the whole amount, orlistat for the whole time. And we can see clearly that once the effect of the medication stops, once the medication stops, the effect of the medication also stops. So this is actually about bariatric surgery. Now comes the question on how much weight loss are we looking at. So in order to have benefits for the patient, we're not talking about cosmetic benefits, we're talking about health benefits. So for patients, in order to have metabolic benefits or even mechanical benefits from weight loss, we don't need dramatic amount of weight loss to achieve that benefits. So in order to have improvement in diabetes, heart disease, dyslipidemia, hypertension, or even sleep apnea, all we need is 5 to 10%. So having said that, it's not that after 10% the patient will not have extra benefits. Actually, the more weight the patient loses, the better. But it doesn't mean we have to reach normal weight in order to have any benefits. So even minimum weight loss will actually have good effect. So here let's talk about some guidelines or guideline recommendations on how to customize treatment into patients. So it has been categorized according to the BMI and to the presence of complications. So if the patient BMI is below 27, usually patient don't need more than lifestyle modifications. But once the BMI exceeds 27, then here comes the benefits of medications, and patients actually might require to add some medications to improve their metabolic profile at least. And the bariatric surgery rule comes at the level of BMI of 35 in the presence of complications, and when the BMI reaches more than 40, then even without complications, the patients are advised to have bariatric surgery. And actually, these levels are reduced for those who have South Asian origin, as they have actually higher risk of cardiovascular disease, even with lower BMI. And recently, some authorities even recommend doing even bariatric surgery if the complications present with as low as 32 figure of BMI. The medications that are available. Sorry for some of the slides are not really quite good because they have been converted from keynotes into PowerPoint. Here are the medications that are used for the treatment of obesity. So what is available here in Kuwait is orlistat and liraglutide. That is GLP-1 analog. And also soon they will come the Contrave, which is a combination of naltrexone and bupropion. I think within next year it will be available in the market also. These medications actually the way they work is through appetite. They help the patient to control their appetites, and that will help them to maintain and go on to the diet. With regard to bariatric surgery, we have records of bariatric surgery for about 15 years, and actually for bypass surgery, it's the results we have is until even 20 years. What is very good about surgery is that the weight loss patient have is maintained throughout all this period, and it has been actually linked to improvement of all, at least most of the complications related to obesity. So here we can see the most noticeable complication that is related to obesity, that is type 2 diabetes. There are reports of remission of diabetes over even up to 10 years, which showed really great results of remission of diabetes. So even this 36% rate of remission that happens after 10 years, this is, I believe, it's really quite good impact of bariatric surgery on obesity. So my take-home message is actually to not underestimate obesity, and to treat obesity like treating any other chronic disease, with continuous follow-up and continuous medications, and whenever it's needed, referral for bariatric surgery. And not to underestimate any weight loss, and always remember that even 5% weight loss has really great benefits on obesity and all its complications. And also to remember that there are many different lines of treatment. We customize the treatment according to the patient preference in the first, and also to the patient complications and health issues that are related to obesity, and even if they are not related to obesity. And thank you.